Good evening. Thank you all for attending the third of the WHS 2025 Fall Webinar Series under the title Chronic Pelvic Wounds and Osteomyelitis. Please note if you have any questions throughout this evening's presentation, please utilize the Q&A box and we will address as many questions as possible at the end of the webinar. As a reminder, this webinar is being recorded. I'm Mohammed Al-Masri, Assistant Professor at Department of Surgery, University of Pittsburgh, and the Chair of the WHS Education Committee. Our moderator this evening is Dr. Tugba Ozdemir, and our speakers, Drs. Lisa Gould and Dr. Christina Megal. And now to you, Tugba, to introduce our speakers and yourself. Thank you.
Hello, everyone. This is Dr. Tugba Ozdemir from South Dakota School of Mines. I'm an assistant professor of nanoscience and biomedical engineering department. And I will give the stage to Lisa.
Trying to get myself back here. There we go. I'm here. So I'm Lisa Gould. Many of you know me. I am a plastic surgeon, having practiced for nearly 30 years now, taking care of very difficult wound problems, both surgically and topically in outpatient wound center. I'm the wound surgeon for our hospital and a past president of the Wound Healing Society. Christina?
Thanks, Lisa. Hi, everybody. I'm Christina Megal. I am a nurse practitioner by training, and I serve in the role of assistant professor and medical director for our wound care program at the Frederick Medical College of Wisconsin Milwaukee campus. I've been in the wound care space since 2013, so 12 years in the space. Had a long registered nurse career before I entered this wonderful specialty. And it's an honor to be here today representing the Wound Healing Society and sharing some tough information. Chronic pressure pelvic wounds are a tough thing to take care of. So Dr. Gould and I would like to kind of do a nice overview and cover, maybe titillate some of our clinicians as well as our researchers into thinking about what we can do to improve care for this population over time. I'm going to go ahead and share my slides. Moment here. One second. My apologies for the delay. All right. Help me as the participants. Are you seeing the notes or are you seeing the proper PowerPoint?
We're seeing the notes. If you go to the top and do display settings and then switch.
Thank you very much.
Perfect.
Seeing the one you want?
Yes.
Perfect. I love having multiple screens. It's always fun to organize. So thank you for bearing with me. All right, let's go ahead and dive in. So the first section that I'm going to cover is kind of an overview of some of the problem that we're dealing with patients, very, very chronic, long-term pelvic pressure wounds. Most of these are stage 4 pressure wounds or have been stage 4 at some point in time. And we'd really like to bring some light to this population and talk about some of the opportunities that we have, like what do we know, what do we don't know, why do some of these wounds heal, why do some of them not heal. So I'm going to cover a little bit of the population, and then Dr. Gould is going to go into the osteomyelitis component that is often a major contributing factor to why these wounds don't progress. Again, as we go along, if you have questions, please enter them into the Q&A. All right, so understanding the depth of the problem. This, as mentioned, is both a clinical and a research issue. So some of the considerations we'd like to bring forth is when you dive into the literature, chronic pelvic wound volumes are not really well defined. Like we don't have a great understanding of the incidence and the prevalence of this condition, who it's affecting, and what the long-term outcomes and challenges that this patient population has. These wounds can be open for years. I have patients who have had these wounds as long as 12 to 15 years, some greater, and they just weren't candidates for flap repair surgery. Whatever they had going on in their life, they just weren't candidates to have anything surgically repaired, so they've had to live with chronic wounds for a very long time. Anyone who has worked in the clinical space like us, the clinicians understand that these are very resource-intense visits. It takes a whole village to take care of these folks. These are often folks with spinal cord injury that need help transferring, so they might be we need a team to be able to manage moving them from a wheelchair to a bed for examination. So it may be 1 or 2 techs, we have nurse involved, we have provider staff involvement, and luckily as we were able to generate data and look at this population of special needs, we also have social work that we can bring in periodically as needed. We know that stage 4 wounds with exposed bone are particularly challenging to heal, and some of them don't progress to healing. So I had an opportunity with, she was a medical student a few years back and is now one of our fantastic plastic surgery residents, to do a data collection project, kind of to dive in and look at what some of these patients look like in our population. So I currently work at a level 1 trauma center. I've been at this facility since 2018. Prior to that, I was in one of our community division hospitals, and we didn't see a great number of stage 4 pelvic pressure injuries. But at the level 1 trauma center, where we are taking care of both violent, non-violent spinal cord injury patients, it's a pretty significant population. So this, the research question for this particular project was, the interest was looking at what risk factors contribute to pressure injury development. So this project by its very nature really helped us dive into our trauma database and look at some of the characteristics of the population. And really it creates a lot more questions, but that's good because that's how we figure out what we need to continue to look into to define this and figure out where we have opportunities for better interventions. In this particular chart review or retrospective review, the inclusion criteria, we were looking at patients that were over 18 years of age. They had some type of traumatic spinal cord injury between January of 2002 and January of 2018. So it was a 16-year span. And we were looking to make sure they had a minimum of 1 year follow-up so that there would be some data to glean into the study. The team looked at the difference between how the spinal cord injury was occurred as well, because the main question was, if there's a violent mechanism of injury, does it make a difference in their pressure injury risk? So the violent mechanisms of injury were labeled as gunshots, assaults, and stabbings. When we get into the data that you see on this slide, the 4th column in the table shows you the percentage of patients that developed pressure injuries. The yellow highlighted area also pulls out that the mean time for a patient with spinal cord injury to develop that pressure injury was 3.7 years with a range of 0 to 15. So it doesn't always happen immediately after that injury. We looked at gender, marital status, the degree of spinal cord injury, and the mechanism, and could see that as high as 56 to 59% of some of the patients from the complete spinal cord injuries to the violent mechanisms of spinal cord injuries had a much higher incident rate of development of pressure injuries. On the very left, you can also see some of the descriptive statistics in this particular population. 59% were white, 34% Black, 26% Hispanic, and then 4% were categorized in the electronic medical record as other or unknown when it came to race. Then we looked at some regression statistics because we wanted to look at each of those risks and see which ones were going to be most predictive of pressure injuries in the population. And the significant findings were the complete spinal cord injury, the violent mechanism of injury, the male sex, unmarried, and then increasing age were all significant predictors of PI development. And this was pretty in line with the patients that we see in the wound care clinic, the outpatient wound care clinic where I work. As we were becoming smarter and more aware of this patient population and the challenges that they come to clinic with and the problems we're trying to help them solve, we wanted to wrap our head around on a way to capture the intensity of the care that this group needed. And one of the sets of articles that have been in the wound care literature for a while is how to provide palliative wound care and what does palliative wound care look like. So I wanted to just kind of touch on the use of the term palliative because we made a choice to develop a palliative wound care program for our stage 4 pelvic pressure injuries that were not on a healing trajectory. And I really want to be careful with the use of this term and make sure that we identify that we're using it in a very respective way in the true meaning of the word palliative, to palliate. When you look at various definitions, we're looking at relieving serious health-related suffering. We're looking at providing medical care that relieves pain, symptoms, and stress caused by serious illness. So the goals that we have in our palliative wound care approach include managing odor and drainage, providing support for ongoing wound assessments and supply needs so that they don't run out of the things they need to take care of their wounds. And then being ready to connect patients and families to additional resources when they need them, such as social work, pain management, immobility specialists, other medical specialties as the needs arrive. These plans of care are all focused on supporting healing if possible, but by identifying a palliative group or a palliative plan, we can set patients up for as much success as we can manage. Now, when we started utilizing the term the palliative wound care program, that also allowed us to track our volumes, which from a wound care business or a wound care clinic staffing perspective, this helps us understand how we need to predict our volumes over time. When we look at patients who have long-term wounds that aren't progressing or are very slowly progressing, we can predict volumes and understand our resources around nursing and tech support that we need. So we started doing a fairly good job around 2023, 2024 of really utilizing the palliative care concept and the palliative wound program. This particular graph comes out of our electronic medical record, and it does show the blue areas are specifically the pressure injuries that are non-healing wounds. There are other wound types that are part of the palliative program, including vascular ulcers, traumatic wounds, diabetic ulcers, but those are a much lesser part of the palliative program. We've really discovered that it is these chronic pelvic pressure injuries that make up the majority of these folks. So we pulled out those numbers a little more separately to look at the palliative pressure injuries so we could define how many folks that we're seeing per year. So as of 2025, we have 81 patients with chronic pressure pelvic injuries that are not healing. Out of these 81 patients, there are 130 pressure injuries. So there are patients that are dealing with more than one of these. And 62 of these patients have an additional diagnosis of underlying osteomyelitis somewhere in the pelvis or in the trochanters. This graph shows a look at our palliative visit volume compared to our overall wound volume at our particular facility. So at this year, calendar year, we've had 6,235 visits at the date that I pulled this slide, and 13% of them are palliative visits, which is an average of 68 visits monthly. So that, again, helps us plan our staffing. We know that we need to have a certain number of or percentage of FTE to support this program. Out of our 272 total palliative wounds, 48% are pressure injuries here. We do track our palliative clinic visits as well. This particular population sometimes has transportation issues or other social issues that prevents them from getting to their appointments. So we can track how many of these visits are completed, how many are canceled, and how many are no-shows. And this just allows us to follow up and help people get back into the program if they fall off. The next section we'd like to show you is the multidisciplinary treatment algorithm that our facility has worked hard on as a team to come up with a plan to provide the most holistic multidisciplinary care that we can. It starts in the outpatient wound clinic often, or it might start on the inpatient side or in the ED. From our outpatient care, we're looking at conducting regular exams of that pelvic or trochanteric pressure injury with bone exposure. We're looking to see if they have sepsis, and then we have a pathway for sepsis treatment. We refer them to the emergency department for that septic workup and timely administration of antibiotics. If they're not septic and we're in the clinic, we will assess to see if the patient is interested in surgical repair, and then we will review the plastic surgery criteria with them to make sure that we can help course correct and involve the primary care physician whenever possible to get nutrition up to par, to get blood sugars under control, to make sure that we are addressing all of their needs to optimize their health for surgery. If they meet the screening criteria, then we refer for outpatient plastic surgery consult, and then we manage that wound following the palliative wound care plan if it's a stage 4 with exposed bone. Our flap repair screening and optimization criteria are built on a number of published articles over the years looking at when flap repair is successful and what the complications are that patients run into. So based in literature, it's crucial that patients are able to meet these criteria. So we're looking at compliance with offloading. All necessary home equipment is in there, so they have the right bed, they have the right wheelchair, the right cushions, so that they can protect that area that'll undergo flap repair. The medical optimization, good A1C, no acute medical issues or infections, active infections. Looking at optimizing nutrition, albumin greater than 3.5, pre-albumin, we look at microvitamins, we look at ascorbic acid. Complete smoking cessation is critical for flap success. Bowel and bladder control or programs to help manage that. Spasticity management. One of the issues is that these patients must be able to lie prone for the surgery and reposition for pressure relief post-operatively. Mental health support is critical. This is not an easy, it's a long healing process. So having that support, the social support as well as that mental health support. And then patient and family, they both have to be willing to commit to that post-op sitting protocol and recovery plan. Now, if we have a patient that we need to send off to the emergency department because they have concern for infection, we don't always know if it's coming from the wound or if it's coming from another part of the body. But in the emergency department and then on into the inpatient process, they'll follow steps such as looking at the sepsis evaluation protocol, pulling in acute care surgery consult if the patient is septic and an urgent debridement is needed. We partner with our hospitalist team for admission and then for the sepsis management if present. And while they're inpatient, we do look at the opportunity to engage nutrition, engage therapy and physical medicine for assessment and optimization if possible. Our wound team is involved on the inpatient side with outpatient follow-up, and we take that palliative wound care focus and we carry it through from outpatient to inpatient back to outpatient. When the patient comes to the outpatient department, then they're optimized, they've kind of made it through their hospitalization. We've been able to address the factors. Our plastic surgery evaluation process involves looking at those screening criteria and the in-depth physical exam and medical evaluation to question and find out if their medical condition would support the surgery successfully. We also want to know if there's orthotopic bone growth. That's a phenomenon where bone grows outside of the normal bony structure that may interfere with the patient's ability to flex or extend their hips or knees, and we may require the partnership of an orthopedic surgeon to manage that condition. So if the patient is appropriate, our plastic surgery team goes ahead and schedules the patient for surgery. If not, they continue on in the palliative wound care pathway while we continue to work on optimization. All right, palliative wound care approach. We use this term a lot. I want to take you through our palliative wound care plan and what we base that on and how we're handling it. So there's quite a few palliative wound care guidelines that have been published in the last 15 years or so. This is a fairly extensive list of what exists. A lot of these focus heavily on cancer type wounds, but there are some, like the palliative wound care one, the pink one in the upper left corner, that recently came out from UMA. This looks at palliative wound care from more than just a malignant tumor type of wound. So our palliative wound care approach, again, we're trying to limit tissue loss with infection control. We're taking a wound care focus where we're preventing infection, managing drainage and odor, manage wound-related pain, and then setting the patient up for success the best we can with monthly visits for assessments and that certification of wound presence to support supply orders. I can't stress that enough. CMS is very rigid about what type of patients are eligible for surgical dressings to be sent to the home for wound management and the documentation required to be in the medical record to support that. So by setting our patients up for that monthly visit, we make sure that they are meeting all of their criteria to keep those supplies coming. I'd like to show you a brief case just to kind of demonstrate everything that we've touched on so far. This is a 32-year-old female who has a history of spastic quadriplegia. She had chronic encephalopathy from a meningoencephalitis episode. She is nonverbal, so she requires total care, and she's completely dependent on her caregivers. She developed a right ischial pressure injury. It was identified in an outside wound clinic from ours, April 2nd of 2025. She came into the hospital on April 11th of this year with multiple medical issues. She had been sent to the ED from her group home to have that right ischial ulcer checked because they noticed a foul odor. She came in through the ED and got admitted. Her CT scan took a look at the underlying tissues, and it did not find any definitive findings of acute osseous destruction at that time. She underwent bedside debridement from our wound care team, and she was discharged home again with a supportive plan of care to help take care of that wound and finish up some of that debridement through an autolytic process. She was then hospitalized again in August of 2025. And you can see here, this is the same wound, but the wound care plan really helped her fill in. You know, she was being offloaded appropriately. She received appropriate nutrition through her G-tube. And the wound care plan supported a lot of new tissue growth. But what proceeded to happen is that the wound now probed to bone. And with this hospitalization, the CT scan did show at this time she had interval osseous erosion of that right ischial tuberosity. She was not a candidate for surgical repair of this wound. She has severe contractures and spasticity. And her family, there's a very complicated family situation, and they wanted her taken care of in a comfort fashion or a true palliative fashion. So at her last visit, this was most recently at her December 4th outpatient visit, you can see that the open wound has all but completely closed. When you take a probe and you go to that center little divot that you're seeing in that upper corner, this still probes to bone. So her soft tissue has repaired itself, but it has not been able to grow over that area where the bone was impacted by osteomyelitis. So we predict that she will have problems with this site long-term based on our knowledge and experience with other folks in the similar situations. She may briefly cover over, but usually these don't stay covered, especially as that scar tissue adheres to those underlying structures. So before I turn it over to Dr. Gould, these are some of the questions that we'd like to continue to explore from this clinical and research perspective. You know, how extensive is this issue at a national and even international level? Is pelvic osteomyelitis different from other types of osteomyelitis? What are the differing opinions that exist regarding the evaluation and treatment of pelvic osteomyelitis? And why do some wounds with underlying osteomyelitis achieve some type of scarring and closure when others remain open with a chronic sinus tract? We would love to know. So with that, I'm going to turn it over.
There we go. I was clicking on my audio and it wasn't. Thank you, Christina, for that lead in, because what I'm going to talk about is the pelvic wounds and osteomyelitis. Specifically, what is it? How do we diagnose it? And when to treat? And I'll preface this by saying I have a very surgical approach to all wounds, and I would not have let that wound sit there for a month without being debrided. But we can talk about that later. Next slide. So which of these pressure ulcers has osteomyelitis? I'll let you take a look at them. The one on the far left, I think you might think is very obvious. The top middle is a small wound, but when you put a Q-tip in there, it probes directly to bone. And then you can look at the others and think about one of the things that I teach is you got to put your finger in the wound. You won't harm it, and you have to know what's going on. Next slide. So what is the difference between pelvic and long bone osteo? First, long bone osteo, which would be in the foot or lower extremity primarily, but it can also be in upper extremity, but not in this kind of case that we're talking about. But those are usually diagnosed with a combination of clinical information and imaging. Plain radiographs get you started, and then the MRI is the gold standard. At our hospital, we have to get a plain radiograph before we get an MRI, even when bone is exposed, which doesn't always make sense. But MRI will tell us how much of the bone is infected, and therefore, if we're going to surgery, how much needs to be removed. The most common organisms in long bone osteo are Staph aureus, with 50% of that being MRSA, Enterobacter, Pseudomonas, Enterococcus species, and Streptococcus. And I've been seeing a lot more strep lately. Common locations are the foot in diabetic foot ulcers or the lower leg after a trauma. Pelvic osteo, on the other hand, is diagnosed with clinical information, but imaging is of minimal value. The MRI has low specificity, very sensitive, 94% sensitive, but only 22% specific, because what the MRI looks at is edema. And there are many reasons that you can have edema in and around the bone that is not necessarily osteomyelitis in the pelvis. The other issues are hardware artifacts. Many of these patients have had some sort of surgical treatment with implantation of hardware. Positioning, Christina talked about the patient that had contractures, and getting someone positioned for an adequate imaging is very difficult. And then if they have spasms, you can't even read it. If they've had prior infections with erosion in the bone, that never really completely goes back to normal, so you can't tell if it's old or new. And then many patients, especially the quadriplegics or the non-spastic paraplegics, may have osteopenia that will make interpretation very difficult. So the gold standard is actually bone biopsy for culture and histopathology. The most common organisms are very similar to long bone, Staph aureus, Streptococcus, Pseudomonas, and Enterococcus, but it does depend on the location of the wound. Sacral wounds and ischial wounds are commonly contaminated with fecal material, and that can change the organisms in the bone. And then the femoral head is a common source with the trochanteric pressure ulcers. Next slide. So pelvic osteomyelitis is really a neglected disease. We don't As Christina mentioned, we don't know the true incidence or prevalence because a lot of these patients never come to any place that can keep data. And there are very few studies, despite the substantial morbidity and economic burden of this neglected disease. Sacral osteomyelitis is probably overdiagnosed and overtreated. If the wound is down to the bone and people do this probe to bone, which actually has a very specific meaning and was intended for the foot, that everyone assumes that that's osteomyelitis, and then they treat with antibiotics. What is our population? Pubic osteomyelitis is very rare and difficult to treat. And it's not what we're really going to focus on today, but it does occur after, say, urosymphysal osteomyelitis with immune-compromised patients or patients that have had a history of radiation. And on the far right is demonstrating the separation and the erosion into the pubic symphysis. I personally have not seen this, and I don't think I want to see it. Pressure ulcers, however, are very common and occur in the spinal cord injury or disease patients. Most of my patients are older adults with frailty and immobility, as opposed to the population that Christina was studying that are mostly spinal cord injury. And then there are the hospital-acquired pressure ulcers that occur during a serious illness, and then the patient is healed from their serious illness, but they have this ongoing pressure injury. You can see in the radiograph of the ischial tuberosity, there's an arrow pointing to the erosion, and in this plain film, you can actually see the erosion. Next slide. But the challenges are trying to decide, is the infection in the soft tissue, is it in the bone, or is it a distant infection? And that's because we lack the diagnostic tools to differentiate between colonization and true infection. Many of these patients will have a concurrent urinary tract infection, so their SED rate, CRP will be elevated, and they'll have a leukocytosis. But the wound, if you've ever been called to the emergency room, I can tell you the wound is always the first thing that they blame. And many patients have a concomitant systemic illness, and their inflammatory markers are always high and don't go down. So the inflammatory markers are not very helpful. That also makes it difficult to understand their nutritional status, because when they're acutely infected, the albumin and prealbumin will be low because they are negative acute phase reactants. And so those markers, which are really not good for understanding nutrition, are even worse when someone has an infection. The radiologic studies are very difficult to interpret. Again, because of osteopenia, it's hard to tell whether there's an erosion or not. If they've had previous surgery, that area doesn't go back. I get lots of reports where the radiologist is calling it osteomyelitis, but I know that I've already been there and debrided the bone, and it's not going to go back and grow a brand new cortex and look normal. You can't tell if it's acute or chronic on the radiologic studies, or resolving versus persistent. Many of these patients lack symptoms. They either don't have sensation, or they have some immune suppression and don't have symptoms of an infection, and so they show up late. And then chronic osteomyelitis may not be curable with antibiotics, so very understudied whether we can actually cure it. It looks like about 50% of chronic osteomyelitis does not respond to antibiotics. And then if a patient has a persistent open wound, that allows the entry of new pathogens. The reference is a little different about the temporal dynamics. It talks about open wounds in the chronic wound communities, but it's the same concept that you may culture staph 1 week, and 3 weeks later you culture something else because you treated the staph, and then the new pathogen comes in and can take over. Next slide. Our Wound Healing Society pressure ulcer guidelines of 2023 do talk about obtaining the bone biopsy for culture and histology, and there is a wealth of references for that with level 1 evidence. And then once confirmed, The osteomyelitis underlying that pressure ulcer should be adequately debrided and treated with culture-guided antibiotics, but we'll talk about that. If possible, a flap reconstruction with well-vascularized tissue can facilitate healing of that osteomyelitis in the appropriately selected patient. Again, level 1 evidence. Next slide. But there are differing viewpoints. So there are the minimalists, and these are references, and I highlighted some of the things that they say in each one, with Crespo in 2020 saying that sacral pressure ulcers, there's no evidence to suggest that bone biopsies and prolonged preoperative antibiotics lead to better outcomes. Wang et al. And Dr. Larson, who also was in Milwaukee, says that there's no indication for long-term antibiotics if surgical coverage is not planned. And Marriott and Rubaye, who have incredible experience with pressure ulcers in the spinal cord population, said that most positive cultures or osteomyelitis is focal and it's not diffuse. So just on the surface, or could be debrided in a small area and not needing treatment with long-term antibiotics. And then there's the group that treat aggressively but don't know how long to treat with antibiotics. And that we have 4 different references, and the final viewpoint of a literature search is that the antimicrobial duration is not associated with the risk of treatment failure, meaning long treatment doesn't mean that you're not going to fail, and that the deep bone samples mostly grow Staph aureus, Enterococcus, gram-negative bacteria, and anaerobes, but most were polymicrobial. That may be due to how those are sampled, and it depends on the surgeon's algorithm for sampling. But what we have to recognize, and this is something we've already said, is that there's very little literature, and all the review articles use the same literature. It's just how they interpret it, very similar to the news that we're receiving today. Next slide. So my surgical strategy, and this fits very well with, I think it's Bunnell, one of the articles from 2016 in the previous slide, is that I do the operative debridement and irrigation. I debride to viable tissue with whatever tool is appropriate, a scalpel, a curette, a ronger, or hydrosurgery, and then I pulse lavage. And then I do the tissue biopsy, because what I care about is what's being left behind in the patient, not what I'm removing. Culture for aerobes and anaerobes, and if it's been a very long-term wound and we're puzzling our heads over it, may send it for fungal cultures and atypical mycobacteria. The problem with fungal cultures is our current cultures take 6 weeks to come back, and so you don't know what to treat. And we suspect that many of these wounds may have fungus in them, but they're really hard to identify. And then I also send it for pathology. If it's an unusual wound, I send the wound edge with intact skin. But most of the time, if it's a pressure ulcer, we know what it is, and may send the debrided tissue. But definitely, if I'm concerned about osteomyelitis, I will send bone, because it's a combination of the bone pathology and the bone culture that gives me the answer. And then the topical dressings after just a debridement would be an antimicrobial dressing, some that tout to be antibiofilm, any way that we can reduce edema. That's hard to do in the pelvis, but it can be done with negative pressure wound therapy. And then, if appropriate, using a topical extracellular matrix or topical collagen over the bone. Next slide. So when we are faced with this in the operating room, the question is, I'm debriding down to the bone, is the cortex intact? If the cortex is intact, I don't disrupt it just to obtain the culture, because then you would be putting a hole in the bone and opening up the patient to potential more problems. If the cortex is not intact, I will debride the bone to pinpoint bleeding, and then I irrigate, and then we would obtain either bone or soft tissue or both for culture and pathology. And the potential results, they were sending bone. The potential outcomes are the culture is negative and the path is negative. Okay, that patient doesn't have osteomyelitis. The culture is negative, but the path is positive. Now what do? You have a diagnosis of osteomyelitis, but you don't know what to treat with because your culture was negative. So you have to treat empirically. The culture could be positive and then the path negative or equivocal. And that would depend on how severe the wound is and what your threshold is for treating with antibiotics. And then the best result is you have a positive culture with one organism and positive pathology. And what I mentioned before about the multiple organisms, if the wound is well debrided and irrigated, I usually get one organism because I'm not sending the necrotic tissue. And then the problem that we face is, what is the pathologic definition of osteomyelitis? There really isn't one. I worked with our pathologists when I was in Tampa to try to find out how they determine what's osteomyelitis. And I thought there would be a grading scale and it would be really obvious, but the pathologist said, no, there really isn't. They may see bone remodeling. If they say acute and chronic inflammation, that is what they use as their definition of osteomyelitis. But you might get both. It might be a very acute osteo. And then there can be focal involvement. It could be just superficial or wide destruction. And it may change how you approach it and where you get your bone biopsy. If there's a very large area of exposed bone, you have to decide what you're going to send. I send as much as I can because a little tiny piece, sometimes you have a sampling error. And that's another problem. Some people do a percutaneous biopsy. They can have interventional radiology do that, and there's a lot of sampling errors with that. And then we have to decide whether to do immediate or delayed flap reconstruction. When I was in Tampa, I was starting to do a debridement first and then start treating for osteomyelitis and then get the flap reconstruction done within 3 weeks so that they're still on the antibiotics that we cultured initially, and rebiopsy when I do the flap reconstruction to determine if there's a new bacteria that has taken over or if it's actually cleared. If the patient is healthy enough and the wound is clean enough, doing an immediate flap reconstruction is not a bad idea. Next slide. And what does flap reconstruction entail? So you can see on the left the small but deep open wound, and the surgical marking shows the undermining in that wound. So I excise the entire wound, and then the middle figure shows the gluteus muscle, and number 1 is where the wound is. I take the lower aspect of the gluteus muscle and swing that over the bone so that it's bringing in nice healthy blood supply, but also a little bit more of a filler. And then I do what I call a dual plane flap rotation, especially for the ischium, where I rotate the muscle first and secure that, and then it's a very wide skin and subcutaneous flap that fills in everything. And then on the bottom, you can see when it's all nicely sutured closed, and it's going to obviously heal perfectly, right? Okay, next slide. So what about antibiotics? And what do we know? So there was a survey of 558 respondents from the Emerging Infections Network of the Infectious Disease Society of America. They asked them 10 questions about stage 4 pressure ulcers, and not all of them actually treat stage 4 pressure ulcers, and it demonstrated a really wide variation in practice. When asked about using oral versus IV antibiotics based on pathogen, they really were all over the place. Some would do IV only for MRSA and MSSA, but then don't do IV for anaerobes or gram-negative bacteria. And some treat with both, and some treat with oral only, especially when they get into the anaerobes, which I find very puzzling. But the article that's cited emphasizes how the answers showed extremely wide variation in a pretty good population. Pretty good sampling of 558 respondents. And then how long to treat is also all over the map. The feeling was that if there had been a full debridement, which we don't really know the definition of a full debridement, they treated for a shorter duration, somewhere between 2 and 6 weeks. But if they got no debridement or only a partial debridement, they treated longer. Or it just depends. So it's really hard to know what our infectious disease colleagues are thinking and what they're up against, except that they're as puzzled as we are. And then there is a quote in that article that osteomyelitis is always or usually treated too broadly or too long with antibiotics. Next slide. It's interesting to know that we've been talking about whether to use IV or oral antibiotics for a very long time. The article from 2012 from Clinical Infectious Disease had this chart in it, and it looks at the bone penetration of the different antibiotics that we commonly use. And it has they have good bone penetration. So the OVIVA trial, which is more recent from 2019, has really changed practice for at least my colleagues in infectious disease, trying to get use of oral instead of IV antibiotics for bone and joint infections. And I think that's important because there's non-inferiority of oral therapy in a large randomized population, and it's so much less expensive, less invasive, less trouble for the patient. They don't have to have a PICC line that can then get infected. They don't have to go to a skilled nursing facility. They can take oral antibiotics at home. And so it really makes sense as long as the efficacy is just as good and the sensitivities show that an oral antibiotic can be used. Next slide. What about adjunctive strategies? Are we seeing recurrence due to biofilm? So in our own journal, Wound Repair and Regeneration in 2018, Dr. Gordia and others at, I think they were still at Ohio State then, were looking at cultures of predominantly sacral wounds, and they cultured the organisms, but in this article they actually didn't report the species. They just reported whether they were gram-negative or gram-positive. But they did note that conventional culture techniques do not detect biofilm bacteria, so they did scanning electron microscopy, which you can see in the photograph on the right. And then they used resorbable antibiotic beads at the time of reconstruction. Next slide. The problem with this study is it's very small in terms of the number of patients that were treated with antibiotic beads. So it's hard to make conclusions as to whether those resorbable beads actually helped, because you can see that only 15 of the patients were treated with the antibiotic beads, whereas 71 got no beads. So that's really skewed towards not using the beads. I saw a few other problems in terms of the patients that were treated with no beads. A fairly high percentage in my practice, or in my experience, a fairly high percentage of these patients were treated with primary closure, which rarely works. So if you have 17.3% getting no beads and they were closed primarily, I would expect them to recur. They had a pretty high rate of complications. That's not unusual for this problem, but much higher in the no beads. And then we have to look at what flaps were done. As I mentioned, the primary closure probably doesn't work well, and VY advancements don't work well, but they didn't do a lot of those. We try to keep the incision away from where the wound was, so rotation flaps are usually the best for almost all pressure ulcers. Next slide. Now, what about bioscaffold? So that I feel is still in the exploratory stage. There are 2 papers that I know about where people have augmented flap reconstruction using some sort of a matrix. And the idea there is that the matrix may treat what we call the hostile wound environment and decrease inflammation, maybe act as a bit of a filler, but the problem with this is we don't go back and open up the flaps to see if it's helped at all. And in my hands, I don't need an adjunct to get a flap to heal. The reason that flaps fail usually is on the edge or something went awry postoperatively with patients sitting on them, or in some of the positioning that happens that pulls on the incision, not that they just open up spontaneously. Next slide. There's only one clinical trial that I could find that's ongoing, at least on clinicaltrials.gov, and that's in Spain, treating osteomyelitis-associated pressure ulcers. We talked about why this is, and we can discuss it more, but it's pretty hard to get funding for these kind of studies, and they need to be big and multi-center. Next slide. So my final thoughts, there's no evidence that pelvic osteomyelitis actually impedes healing or that antibiotics improve healing, but it does take a village to heal these wounds. It's a multidisciplinary and interdisciplinary project with plastic, general, sometimes orthopedic surgery, although my orthopedic surgeons won't look at wounds. Infectious disease is important, primary care, home health, family caregivers, and most important, the patient at the center. I will not do a flap on the patient unless they can really do the offloading that's required afterwards and understand that it can be a minimum of 6 weeks of bed rest, which they're already tired of bed rest by the time they get to me. Nutrition has to be optimized and the patient has to be optimized. And then there are nursing services, both inpatient and rehabs and skilled nursing facilities, but it is very hard to transfer patients to skilled nursing facilities because they want it to be a short-term rehab and not a long-term convalescence. Christina is very fortunate that she has social services in her clinic, but the patient really needs a good support network and needs comprehensive discharge planning. We need more research. We really need to know whether sacral bone is different than the ischium in terms of osteomyelitis and treatment. Most studies that are in the literature focus on sacral. We need a better definition of what osteomyelitis is, that we can work with infectious disease and our pathology colleagues to get something that's a true definition. I assume that there are new or emerging diagnostics and figure out what biomarkers might be helpful for osteomyelitis. That's a good project for Wound Healing Society members. And we need randomized controlled trials that would determine the impact of bone biopsy on diagnosis and treatment decisions, helping us understand the breadth and duration of antibiotic therapy and the impact of the biopsychosocial factors on healing pelvic pressure ulcers, insurance issues, depression, all the other things that go along with trying to get these patients to heal. Next slide. I think we're done. We can ask for questions.
Well, thank you, Dr. Gould and Dr. Megal. We have lots of questions, so I will go from the first one. So Yang Wu asked how infection is defined in the slide with palliative wound tracking, all wound types. I think, Christina, that's for you, for your slides. She asked that time.
But can you say that question one more time?
How infection is defined in the slide with palliative wound tracking dash all wound types. I think it's one of your first data.
We're using it. We're not tracking infection in that slide. We're tracking the types of wounds. So we're using our electronic medical record to diagnose and define the types of wounds, and then we're able to track the numbers of those wounds that we have. And we can look at it by week, we can look at it by month, by year, but it gives us an understanding of what our practice is and the kind of patients that we're seeing.
I hope this answered your question, Yang. Otherwise, please feel free to ask again. So the next question is from Laura White. Have you thought about taking your palliative program mobile? Perhaps patients who have high barriers to getting the clinic with transportation. Probably this is a suggestion.
It's a beautiful idea. Our organization does not have mobile wound care at this time, but it's a wonderful idea.
And she made a nice comment about, I should share that is impressive stats regarding the clinic. And Laura asked another question. How do you get dressings for the palliative wound patients not having surgery? And what are their limitations on dressings?
That's a wonderful question, and it could spark another hour-long Wound Healing University talk. But the high-level answer is that we do follow the CMS.gov surgical dressings policy. And in that policy, it defines the types of wounds that are eligible for dressings to be ordered. And yes, surgery is one indication or one situation that allows those dressings to be ordered. But as long as some type of debridement has been done, and we do debridement in the clinic, we are cleaning those wounds to remove biofilm, to make sure that we're if there's slough or necrotic tissue, we're getting that out of there. But we are cleaning, whether we're doing mechanical, autolytic, or sharp debridement. And we're clearly documenting that so that these wounds are eligible for dressings.
Yeah, I'll add to that. All they have to have is one debridement, and they're still eligible for this category. So even a mechanical debridement, which is with gauze, you just have to document it. And I have been fighting and fighting and fighting with the Alliance to get us to say that they're not surgical dressings. But, well, I'm not fighting with the Alliance. I'm trying to get the Alliance to fight with Medicare about that definition, because I think it's a terrible definition. If you have a wound that's heavily draining, you should be allowed to use what's appropriate for it, whether they've been debrided or not. But there we are.
Yes, agreed.
With that, I think this question for you, Lisa. Does the data exist on how many people live with osteo versus die from it, or data of osteo to sepsis?
So somewhere in our guidelines, there is one article where they did, it was a post-mortem analysis of whether they had osteo or not. We don't know that they died from their osteo. We just know that they died with their osteo. No, I don't think we have that data. I do know that Superman died from his pressure ulcer because my former resident took care of Superman, and he would not let anybody look at that wound, and that was his demise. So he was quadriplegic, and if you look on the Superman Foundation, which is it's Christopher Reeve's foundation, they only care about curing spinal cord injury, and they still don't fund much for pressure ulcers. We really wish they would change their mind, but it's I think it was a matter of pride, and that's one of the problems with some of our patients. They don't feel it, and then they don't want anybody to look at their backside until it's too late.
Well, thank you. And I just want to extend this comment from Laura White to both of you. This was a great presentation.
Thank you.
And I agree. Thank you, both of you.
Happy to serve.
Yes.
Yeah, I think we are almost heading to the time. Thank you very much, our wonderful moderator and the speakers, Tugba and Lisa Gould and Christina Megal. Thank you very much for this wonderful webinar. And thank you all for attending our chronic pelvic wounds and osteomyelitis webinar brought to you by the WHS Education Committee and Wound Healing U. As a reminder, the recording will be available in your member-only account or in the Wound Healing EU and on the WHS YouTube in the next few weeks. Just a reminder, in February 2026, we will have a webinar on wound care basics with Lisa Gould and Foy White Shoe. And then in March, we have Romana Aslam and Elizabeth Garfield will speak on lymphedema and wound care. Again, thank you very much and have a wonderful evening. See you in the next webinar. Thank you.
Bye, everyone.